And let's see if there's anything to add for the pelvis and the hip. When we talk about the pelvis, any neurologic things that are going to be in this area here? So we'll talk a lot about sciatic nerve. Is there any other peripheral nerves that are relevant in the hip and pelvis? What would you call this area? I mean, this is the thigh, right? If this is medial, this is lateral. So you heard of the lateral femoral cutaneous nerve? It's part of the lumbar plexus. You can get a condition that's called Brown's parasitic, then we'll talk about that. What's another nerve right here that can get irritated or trapped? Yeah, the femoral nerve. We have some tests for that where you're stretching back. So if there's nerves that have to do with the front, like the femoral nerve, if we're going to stretch that one, since we talked about the spinal cord and the sciatic nerve is more or less to the back part, we're going to stretch it this way. How are you going to stretch the femoral nerve? Flexion or extension? Yeah, so we'll do a test where we extend back like that for the femoral nerve. And then as far as red flags, in the history, if you hear of something where somebody's taking, use of steroid drugs or things like that, or pain can radiate from internal organs that can go into the low back. So certain things like if pain is severe, there's no mechanical origin to it, it's not relieved by anything, it's progressively getting worse, there's sudden gain or weight gain or weight loss, things like that are going to trigger you to think, well, maybe there's something else going on here. All right. Any questions? So, like I said, at this point we're going to kind of switch things around a little bit. So if you're following along in the notes, you're going to skip forward to the part where it talks about the exam. And then we'll go back more into detail on this later. We'll talk about the conditions. Okay, so you're going to take a history. So here you can see this is the injury that's happening, right? You've probably seen this before, right? There's a little problem with the video when it shows out. But if you want to take a history, how did it happen? So what would this be, an acute injury or chronic injury? It could actually be chronic because every time that she goes and puts the football out, she pulls it away. So it could be an acute exacerbation of a chronic condition. So you're going to do your observation, palpation. So when we talk about in the pelvis, we talk about lumbopelvic range of rhythm. Okay? It's kind of like when we talk about scapulothoracic, right? So when you flex forward, there's two things that go on. You have flexion in the lumbar spine, and then you also have flexion at the hip. So when you flex forward, you're flexing at the lumbar spine first, and then as you come farther forward, you flex at the hip to get bent forward all the way. So when we measure range of motion, if you're using dual inclinometers, you can take the pelvic range of motion out and subtract it from the lumbar range of motion by putting the two different things here. If you're using the goniometers, it's a little more difficult to do that. But so when you're watching the range of motion, you're not only looking at how far they can move, but also the quality of the range as far as somebody can bend like this. If they have tight hamstrings and you see somebody bend forward like that, that's different versus if they bend forward like this. So here you're not flexing the lumbar spine, you're bending forward at the pelvis and the hip. Okay, so the difference, you want to be aware of that when they bend forward. And then also when they extend, it's the opposite. When you come back, when you extend, first you should have a reversal of that pelvic tilt. Or that's actually a pelvic tilt. So you want to have pelvic motion like that, and then the lumbar lordosis comes back to normal. If there's abnormal rhythm, somebody goes to bend like that, they hyperextend their lumbar spine first, that's going to be where they're more likely to have an injury to the lumbar spine, either the facets or something like that, versus if they do the normal motion where you should do a pelvic tilt first, and then the lumbar spine extends. So when you're looking at range of motion, it's not just a matter of how far forward can they bend, how far back can they bend. You want to look at the process or the steps that it occurs of how they move. So again, now in this case, we're going to be doing thoracic and lumbar range of motion together. You can do them all together as one thing, or you can separate them out. So you're going to be able to do more separation and isolating different ranges of motion if you're using inclinometers. If you're using goniometers, it's going to be hard to separate the thoracic from the lumbar. And some of you in practice, you're not necessarily going to get into all that detail of range of motion, but at least we'll go over it and you can learn it in here and then do however you want when you get out. So these numbers here are out of the book, and they're referring to flexion just of the lumbar spine and isolating out the pelvis out of it. Okay? So you might see different values in different sources where they'll talk about lumbosacral flexion at 90 degrees, meaning that you basically have 90 degrees from the femur to the lumbar spine. And so that's using the hip as part of it. If you take the hip out of it, that's where you're going to get a number more like 60. And then the other thing, just like in the cervical, when we talk about looking at the space between here to evaluate it, the other way that they talk about is measuring the distance between how far your fingers are from the floor. So that's another way, a more simplified way of measuring it. And so we'll go into the detail of all these: flexion, extension, lateral flexion, rotation. Rotation, there's not really that much in the lumbar spine. And then, of course, you always do active range of motion, passive range of motion, active resistant range of motion. And then these are in the notes. It talks about where the fulcrums and the mobile arms and stationary arms. And we'll go over that later. I don't have this text on the inclinometer stuff, but I'll probably get that, and we can either pass it out or put it on the secure site. Basically, with the rotation, it's kind of hard with goniometers. It's the same kind of thing that we did with the cervical, where you got to sit them down and you look over the top, and it's at best an approximation. So then with the 5-minute neuro, again, it's the same kind of stuff. You're going to have dermatomes, myotomes, and reflexes. Right? And then this came up with, I know I've mentioned this before, but we'll mention it again. When you're doing myotomes, how long do you hold it for? 5 seconds. If you're doing like if you're doing manual muscle testing, you may not necessarily hold it for 5 seconds, because usually when you're doing a manual muscle test, it's just more of like a quick type of thing. Maybe that's where because people were saying in the midterm that they were taught that you just hold it just real briefly. That may be more for when you're doing manual muscle testing, whereas in myotome it's more of a neurologic test, so you're doing it for a longer period of time, 5 seconds. And then the dermatomes. I mean, you can cover pretty much most of the dermatomes on the foot here. The primary ones are going to be L4, L5, S1, but you also want to be aware of S2. And then basically the way it works is that when you start from the lumbars, it goes in bands like this. Usually L1 is going to be here into the inguinal area, and then it just spirals like a barber's pole, coming down L1, 2, 3, 4. 4 goes down into here. And then you get 5 on the upper surface of the foot, and then S1 on the lateral side. And then to get into S2, you're talking about the back of the leg here. And then myotomes. And mostly you're going to be talking here from L4 down, but you do need to be aware of these other myotomes here. So you have hip flexion, knee extension. And you want to make sure you don't get mixed up because the reflexes and the myotomes are different. Right? So you have the patellar reflex is going to be one thing, and the myotomes in that area are a little bit different. And then also some of these, like heel walk and toe walk, so when you're doing the gait analysis, you can have the person walk on their toes, walk on their heels. Have you guys gone over that? Okay.